Thank you very much for your kind presentation. It's an honor to be here with you in this great place with great weather and also with great people. So thank you very much for the kind invitation. To speak about this amazing, but I think that controversial topic, which is GLP-1 agonist in the treatment of patients with psoriasis. So we have been talking about obesity for the whole day, and obesity, I think it's one of the main drivers of treatment failure, but also the reduced survival in patients with psoriasis. So my goal here in this talk is providing the evidence from clinical studies showing the effect of this GLP-1 agonist in patients with psoriasis, to see the effect on psoriasis itself and also the comorbidities of patients in psoriasis, mainly obesity and diabetes mellitus, which are the two main indications of these drugs. I go back to this slide. We have seen this slide this morning. And I want to focus here on the physicians, the dermatologists who are willing to prescribe these drugs to patients with psoriasis. As you can see here, around 20% of us are doing that. So the interest in our field is learning how these drugs function and which is the benefit, to find the benefit in patients with psoriasis. And as you can see here, most of the physicians, the dermatologists who prescribe GLP-1 agonists are based in Europe and in North America. So why is it necessary, or it may help us, the use of GLP-1 agonists in general to reduce the weight in patients with psoriasis or without? The point is that when after food ingestion, the gastrointestinal tract produces three different hormones called also incretins, GLP-1, GIP, and also DPP-4, as mentioned before. And the main functions of these drugs are to reduce the appetite of the patient who is taking the drug. Second one is reducing the emptying of the gas of the stomach, and later on increasing the sensitivity to insulin. And all these metabolic effects induce at the end an overall weight loss and also metabolic regulation. In psoriasis, we can only see 4 to 5 clinical trials, specific clinical trials to study the effect of these drugs in patients with psoriasis. Also, as mentioned before, some other indications will come in the future. Some of them also will benefit patients with psoriasis. This is the case of hypertension, atherosclerosis, heart failure, and also alcohol abuse that is also very common in our patients. And maybe in the future we'll treat with these drugs other diseases, other conditions such as polycystic ovary syndrome or even knee osteoarthritis. Let's see in the future what of these indications are approved. For the ones who want to start treating patients with these drugs, I have to tell you that the most commonly used are these three drugs, semaglutide, liraglutide, and tirzepatide. The two on the top, semaglutide and liraglutide, are GLP-1 selective receptor agonists, whether tirzepatide is a dual agonist. It's an agonist of both GLP-1 and GIP. All of them, the three molecules, are injected subcutaneously, but semaglutide has also tablets to do an oral treatment. Also, the approach is a little, you have to know it before starting the treatment in a patient, because for semaglutide and tirzepatide, the patient is usually on an initial therapy doing the same dose for weeks, for a month, and after that, patients can increase the dose weekly. And with semaglutide, the maximum dose is 2.4, and with tirzepatide, 15 milligrams. But it doesn't mean that the patients need to do exactly this dose. They then keep doing an inferior dose. It depends on the patient and the needs they have. And finally, liraglutide. This is a bit different because it's also subcutaneous, but it's administered once daily, and the patients usually start at 0.6 milligrams per day, and after 10 weeks, they can increase the dose to 1.2. That is usually the dose that is commonly used in patients with obesity. So I'm sure that you have heard about the benefits of these drugs, but also about the side effects. As you can see here, most of the side effects are related to gastrointestinal, to digestive system, being the nausea and the vomiting, the main symptoms that these patients can present. You will see also lots of papers on pancreatitis and side effects related to the pancreas, the liver, and the thyroid gland, even cancer. But I have to tell you that some of the data that you can see here are not confirmed in the last meta-analysis that have been published recently. So I think that we need more long-term data to really confirm which is the safety of these drugs in patients, in general population, but also in patients with psoriasis. What seems to be clear is that those patients that are being treated with GLP-1 receptor agonists have an increased risk of aspiration during a surgery that requires general anesthesia or sedation. So the recommendation is to discontinue 1 week prior to the surgery or the procedure is performed. So what is the evidence in psoriasis? The evidence in psoriasis is not really high. We have, as mentioned before, a couple of clinical trials for each molecule, but it does make sense to block GLP-1 in patients with psoriasis, as mentioned before by Dr. Liao. I also want to comment here that it does make sense to treat psoriasis with these drugs because, as you can see here in this expression panel, patients with psoriasis have an increased expression of GLP-1 receptor in the skin, whereas the unaffected skin of these patients have reduced levels of this molecule, and the normal skin from healthy volunteers do not express lower levels of these receptors. So it does make sense to treat patients with psoriasis because psoriasis does express this receptor. So since the approval of these drugs, the interest of dermatologists has been increasing over the time, and I will only mention the studies that have certain evidence. Here we have the first prospective cohort study that was published with only 7 patients, and the follow-up was 10 weeks. The patients were treated with liraglutide 1.2, but I have to mention here that most of the studies are done in patients with psoriasis, obesity, but also type 2 diabetes. So it may be a confounder in some of the studies. But the important is in most of the studies, like this one, we will see that usually the PASI drops from, in this case, 4.8 to 3. That I think it's not much, but the difference is significant. And the main limitation is the low number of patients included in this work. Later on, a meta-analysis on this topic shows similar data for only 4 studies were included in this meta-analysis with 32 patients treated in between 8 to 16 weeks. And again, those patients treated with these agonists had a reduced PASI after being treated with these molecules. At the same time, the patients show lower fasting plasma glucose levels with no difference in the body mass index. So it seems that liraglutide liraglutide therapy can reduce psoriasis in patients who also had concomitant type 2 diabetes, and that it's independent in changes in weight and glycemic control. This is one of the 2 clinical trials, randomized clinical trials with GLP-1s in psoriasis. Again, patients with psoriasis, obesity, and type 2 diabetes. And as you can see here, this includes only 24 patients. The follow-up is 12 weeks. And again, the PASI is reduced in patients, significantly reduced, decreased in patients treated with these molecules together, at the same time with the reduction in both weight, BMI, and waist circumference. So suggesting that, again, patients with psoriasis, but again, type 2 diabetes can have some benefit when treated with these drugs. But I have to tell you that there are some controversial data against the data presented before, because here we have one of the clinical trials showing exactly the opposite. In this study, 20 patients that were glucose tolerant, so the patients were not diabetic. In this case, the benefit couldn't be demonstrated. So in this case, patients with obesity and psoriasis but who are not diabetic do not show a reduction in PASI. So it's a little bit controversial to put all these things together. Later on, this is the last study that has been published that belongs to a group in Spain, in Mallorca. This is a prospective cohort with 48 patients, and this is the study with a longer follow-up, that is 6 months. In this case, patients were treated with liraglutide 3 milligrams during 6 months, and here again you can see that the PASI reductions goes from 12 to 0.43, is around PASI 75. So PASI 75, so it's not bad. And what is also interesting is that the dermatological improvement was independent of the weight loss of the patients. And what about semaglutide? Semaglutide, we only have this clinical trial with 31 patients, psoriasis and again type 2 diabetes. 15 patients were treated with 2 molecules, semaglutide and metformin at the same time, whereas the other group was treated with metformin alone. And as you can see here, the decrease in PASI in the patients that were treated at the same time with the semaglutide and metformin, the reduction of PASI was higher than the patients who were only treated with metformin, suggesting the effect of semaglutide in the reduction of PASI. And finally, this is the last study I want to show you. It's again a prospective cohort from the same group in Spain with 43 patients, but in this case the patients were treated with semaglutide. In this case, patients were obese but not diabetic, and again they show a significant improvement in PASI that is interestingly independent on the weight loss of the patients. I think that probably there is a combination in, as mentioned before by Professor Liao, the reduction on the weight, but also a direct effect in the metabolism. But what is important is that with these drugs, we are probably reducing the mortality of patients when we treat patients with psoriasis with GLP-1 agonist. This study has, again, this is a Trinitex study. It has limitations, but maybe when we start treating our own patients with psoriasis and these drugs, we can have prospective data and take conclusions in this sense. So I think that we cannot conclude that which is the benefit of these drugs in patients with psoriasis. I'm convinced that the weight loss has an effect, not only in psoriasis itself, but also in comorbidities. Some data here show that maybe some of the independent data depend on diabetic status of the patient. And the main limitation is that most of the studies are really short-term with a small number of patients. So what we do really need is a larger study, a long-term randomized control trials with these drugs to really validate which is the real benefit in patients with psoriasis. Thank you very much.
Thank you. Can I ask the first question? Right. Now, when I have a psoriasis patient, all these trials have been done with only using the GLP-1 drugs, no other anti-psoriasis treatment. Mm-hmm. And some of them were obese, some of them were not, some of them were diabetic. There are so many confounding factors, I'm not really sure. What I came up with at the end, that if I have a diabetic, obese, psoriatic patient, he might benefit, plus the anti-psoriasis treatment. And of course, like Joel was just said, we need trials. I cannot. And what about metformin? Metformin in Egypt, Egyptian dermatologists love it. And they really write it. It's a very cheap drug, extremely cheap, available. A lot of Egyptians are on the drug, whether diabetics or non-diabetics. So what do you think about that?
Well, I think that we can use what we have, and what we really need is to have prospective data and clinical trials with a huge number of patients in order to study the effects on different patients, even in patients with no comorbidities, yes. Patients with psoriasis and normal weight, yes. With no obesity, yeah. To see which is the direct effect in the inflammation and the psoriasis itself. So we need to do more work. Now we have a clinical trial from Lilly to study exactly which is the effect of the combination of ixekizumab with tirzepatide. I have not been talking about tirzepatide because we have no data yet on psoriasis, but we will have in the future with both psoriasis and both psoriatic arthritis, so we will have more information on that.
Any other question?
I was going to say, to me, looking at the literature so far for the effect of GLP-1s on psoriasis is modest at best.
Yeah.
But to me, the big role, we know with biologics, every biologic is better in thinner people. And so for me, the combo of GLP-1 plus biologic is going to make biologics work better. It's almost for certain. Yeah, sure. So I just I don't love all the talk about GLP-1 independent effects on psoriasis when it looks pretty modest to me.
The point is that I don't think that we are going to treat psoriasis with GLP agonists. GLP agonists are to help to get better outcomes in our patients. Right. The patients that are treated with drugs, biologic drugs, of course, I don't mean to treat them only with GLP-1 agonists.
But it is an interesting thing we have to grapple with, because if you're a payer, you'd be very interested in knowing if a GLP-1 can make psoriasis mild enough that they don't need more expensive therapies, and some of these people with more mild disease will clear probably, sure. Right? Or trying to understand that out, right? Well, if you're a payer, would you like to spend $80,000 a year for life of a biologic to treat psoriasis, or it's roughly $5,000 a year for a GLP-1 that has mortality benefits?
It's not going to be past the 100.
No, but I'm talking about there's a huge spectrum of psoriasis out there, right? There's a lot of people with limited psoriasis, 1% to 2% of the body surface area. Those people may benefit from this. Right. Well, yeah, but this could do inhibitory.
Last question. Okay.
Thank you. One last comment. We think when we treat psoriasis, we want to look on dermatological indexes. And when I would say general physicians or family physicians will treat patients with obesity or hypertension or diabetes, they look on their outcomes. But I think maybe it's about time that we think about the patient as a whole. And I would advocate for combinational therapies. I would add GLP-1 receptor agonist into our treatment paradigm, and then we are not treating only the psoriasis, but treating rather the patient as a whole. This is a very high bar to get to in clinical studies, but I think that is correct in my opinion.
Sure, I agree with you. I think that we need prospective clinical trials to study this specific effect on patients with psoriasis.
Thank you, and thank you so much. Thank you.